Okay, good evening, everybody. Welcome to the Multi-Medix webinar series on Ultrasound Quality Assurance. This is the second webinar in our series of 4, and today we're going to be taking you through user, QA and audit as well. My name is Marilla Stevenson. I'm going to take you through a few administrative points first of all this evening. If you can keep your cameras switched off, then that always helps with any lagging issues that they might occur. If you can leave your questions till the end, the last 10 minutes, we'll deal with them then. And if you can write them in the chat panel, that would be great. The webinar is going to be recorded, so if you'd prefer not to be recorded and your comments not to be recorded, then that's absolutely fine to leave now. The recording will be up on the portal around lunchtime tomorrow. And if you have any issues with audio, any technical issues, either during today's webinar or in between the webinars, then I'm going to put my email address in the chat panel in a minute. And please do email me and I'll endeavour to help you. But lots of emails in between the 2 webinars, generally asking about QA, about the book, how to go onto the portal, all sorts of things. So please don't hesitate to ask. Our presenters today, again, are Darren Woolley and Nick Dudley. And in the last session, I gave you their resumes. You know that they are active champions when it comes to ultrasound QA and have, you know, decades of experience between them. And you really couldn't be in better hands this evening to have somebody take you through some of the demonstrations in terms of user QA, which is what they're going to be doing. Before we start, though, I would like to just do a quick poll, actually. So hopefully you can see that up on the screen. There are 2 questions that I'm going to read out because I know sometimes in the recordings the polls don't actually show up. And you can't answer them just yet, but if you just, let's remind ourselves, first of all, what we were looking at in the previous webinar. There was a very important figure that was mentioned. And that we stressed in terms of the percentage of faults that could be found through checking and inspecting probes and doing a uniformity check. And you've got 3 different options there. And in question 2, we're asking whether in the last 7 days you've done any ultrasound user QA, and we're certainly not expecting you to have completed and implemented an entire QA program in 7 days since the last webinar, nothing like that at all. But we're just interested to see whether after the first webinar you have gone in and inspected probes, or you've initiated a discussion even amongst your colleagues about user QA, perhaps just flicked through the book. Any of those things would count as having done and contributed towards some form of ultrasound user QA in the last 7 days. So I'm going to launch the poll and hopefully you're going to be able to put in your answers. I'll give it a couple of minutes. Just give it another couple of seconds. Okay, so I'll call it there, so I'll end the polling. So for question 1, the percentage of faults that you can find through checking and inspection of probes and doing uniformity check is actually 90%. So quite a lot can be done just through looking at the probes and doing that particular check. So well done those of you that got it right. And for those of you that thought it was 60%, it should be great news that you can find so much through those sorts of simple checks. And in the last 7 days, the number of you that have been able to do some form of user QA is 4 of you. So that's about 67%. So that's pretty good, actually. And I will be sort of checking in each time we do those webinars just to see how many people have been able to make a start on doing some QA in between the webinars. And that reminds me that in our very final session, the session is going to be about implementing QA, how it interacts with your CPD and so on. So I will close that down now. And that brings me on to our demonstrators this evening. We've got Dr. Nick Dudley and Darren Woolley. They're going to be demonstrating some of the user QA checks that you're going to be able to do and inspire you to implement some user QA in the next 7 days. So I'll hand over to you, Darren and Nick.
Thanks, Marilla.
Thanks, Marilla.
So to get us started, I'm just going to ask Nick to just summarize for us why user QA is so important.
Thanks, Darren. Well, apart from the legislation and the guidance that tell us we should be doing QA, I think we should think about the patient and their right to expect the equipment to be working properly. So the patient for me is the number one driver for QA. We need to protect them. And we need to pick up faults quickly. So I think we need to build a program around the user. And that way we're going to offer the patients the maximum protection. The beauty of the tests that we're going to describe today is that they only take a few minutes. And as Marilla has said after her poll, it should pick up more than 90% of faults. And also the benefit of these simple tests is if we're all doing it the same way, staff who move between jobs won't need to relearn a QA system. Hopefully they'll have some good habits from doing this simple user QA.
Great, thanks for that, Nick. So let's dive straight in, shall we? What should users be doing then?
Well, on a daily basis, it's good practice to have a quick look for obvious faults. It's not going to take very long. Things that users are probably doing already, like looking after the probes and keeping them clean. Of course, remember when you're keeping a probe clean, not to rub it, just to wipe it. I've seen lenses rubbed off probes, so be careful about that. And then as a minimum of monthly, I would suggest there's a formal regular inspection, a uniformity check using a special user QA preset, which we'll talk more about next week, and a very simple test of sensitivity. And check your monitor and hard copy settings. Obviously, they have to be right in order for you to get the best images. And make sure you document everything, because if you don't document it, it's as if you haven't done it. So those are the basic things. We'll go into a bit more detail in those now. And Darren, could you tell us a bit about the physical inspection?
Yeah, of course, Nick. I've got a fairly common looking linear probe available for us now. And we break inspection down, and it is also listed in the manual if you've got access to it in pages 20, 21, etc. But what we tend to focus on is looking at the lens first, which is usually quite a delicate silicone material. It is prone to wear if you're over aggressive with cleaning, and it can be just prone to wear through use and just good cleaning practice even. But we look for damage or delamination, which is where it might raise up and separate from the array beneath, and just a little push with the thumb. And if it bubbles up, that's kind of a good example of delamination, but a good inspection of that. For those eagle-eyed, this isn't a perfect probe for demonstration purposes, so therefore it's got some damage on the lens. You might just be able to see the shadows here. So we would note that and see whether it's going to affect our imaging and risk assess it. We'd look at the casing. So the casing joins. This can be a problem for infection control or electrical safety, as can damage to the lens. We would look at where the strain relief comes to the cable, and we'd look at for the conditionality of that and for the seal. We'd inspect the length of the cable, and that's best done really using your hands. Finger and thumb will detect any defects. There's a lot of micro coax cables in there that are very fragile, and if they break or fracture, that can affect imaging quality. So they're the kind of the key stages. It would be worth just having a look at the connector if it's a probe that's plugged in and out regularly, looking for mechanical damage. Some systems, the probes stay very static, so you're unlikely to get connector issues with those. But it's really about lens, case, strain relief and cable. And they're the very simple things you can do very, very quickly and easily.
Thanks, Darren.
So what about looking for a bit more beyond just the physical, Nick, and function. How do we quickly assess that from a user perspective?
Yeah, the obvious thing is to report any control faults when you find them. You'll see those in clinical use. Then for the formal test, look at the uniformity of the in-air reverberation. And this is best done with a user QA preset. We're going to talk more about next week. Compare it with previous images if you can, if you think there's anything wrong. And then if you think you see any dropout, you can do the paperclip test, which we're going to show you in a moment. There are other non-uniformity issues you might find. Darren mentioned delamination, where the lens is coming away from the array and you'll see a blurring of the reverberation pattern. And then there's more gross non-uniformity where the probe might have been dropped and a big chunk of elements damaged. If you do suspect any dropout, which you'll see as axial banding in the image, then let me just share my screen. Okay, then you'll see these axial bands here, and notice that on clinical settings, the top one, you can't really see anything. So this QA setting is quite important. Then once you've seen these bands, you need to know whether it's element failure or maybe it's something else, something to do with the lens. So you run a paperclip across the array and you'll see that where the dark bands are, the reverberation from the paperclip dims. So that tells you there are some dead elements, possibly element damage or a cable fault. Darren, you've got a scanner there, haven't you, and a probe where you can show us this test?
Yes, yeah, thank you, Nick.
Real time.
I'll flip screens for us and we will demonstrate that live on this webinar. So I've just got it's the same linear probe we've just looked at, and I've just got it set to a typical preset. I could have set up a QA preset, but as we start, we might note there's a little bit of change in the air reverberation pattern, but what we'll demonstrate is if I mimicked what our QA preset would show, we would be turning off advanced processing like harmonics, S-Res and Sonar CT, selecting a high fundamental frequency, but also then manipulate our depth and focus towards the top of the image. And I think if we just freeze that there a moment, we can see that that's changed dramatically to our eyes. So we can see a lot of the dark bands that Nick was talking about. When it's in this mode, we can apply the dropout test. Typically apply a small film of water to lubricate the lens, and either a paperclip or a test tool that Multi-Medix has available. We use that just to sweep across, as Nick's described, and we will see flashes of it going on and off. So I move across the dark axial bands. And that's an example of just how easy it is just to very quickly identify non-functioning elements or cable breaks. I do know for demonstration purposes that this probe has got a problem with its cable, so a little bit of gentle manipulation and we should see some of them flashing on and off just there. So that could be typical of an intermittent problem as well. So we'll switch back to the other screen. We'll bring Nick back in for us. Hopefully, Nick, that was able to demonstrate what we were trying to show the users.
Yeah, that was very nice. Thanks, Darren. Now, before I talk about the next test, it's quite important to check your monitor. So if you look at the grayscale bar that's often on the left or the right of the screen, you're looking to see if all the gray levels are there, and you can check that by turning the brightness up and see if any more appear. And there shouldn't be too much white at the top. It should just be the top part of this that's white. If it's not, you need to adjust that to get that right. And the same for your hard copy. And then there's a very simple test for sensitivity. This isn't an absolute measure of sensitivity, but it tells you if something's going wrong. What you should do here is measure from the probe face to the deepest visible reverberation. And my rule with that is if you can see it, measure it. And this test is quite reproducible. And then you look at this last reverberation and turn the gain down until it just disappears. And I've called this the reverberation threshold. You write down the gain value there, and that's a second measure of sensitivity. And obviously you need some tolerances on this, which we'll describe next week when we talk about baseline testing. Another test you can do for cable faults is to turn on color Doppler and just flex and shake the cable. And if you see flashing like this, that tells you you've got a cable fault. I'm going to stop sharing now because that's the end of the user tests. Very simple.
So Nick, one of the things I know that people come across is probes being moved between scanners. How do you propose we manage that?
Yeah, that can cause a bit of difficulty, but the physical inspection and uniformity checks can be done independently of the scanner. So you can move probes around and still do those checks as long as you have the user QA preset for the probe on the scanner. Sensitivity measurements aren't independent of the scanner. So really you need to either bring the probes back to the original scanners or do the baseline tests on every scanner that you think you're going to use that probe on, so that you don't then have to move them back. So two approaches depending on what's going to work best for your department.
Great. So we've got some good physical inspection going on, some uniformity and some dropout checks. You've talked about some sensitivity measurements and looking at Doppler noise that might pick up cable breaks. So how do we know it's all coming together and working, Nick?
Okay, I'm going to share my screen again. So once you've been running QA for a little while, once you get started, maybe after about 3 months, start doing some audit. And all you're doing here is trying to tie up loose ends and make sure it's all working. So the first thing is to check whether it's actually been done. I can't see the top box on my screen. I don't know whether you all can, but it asks whether the monthly QA was completed. So you're checking that. Check that anything out of tolerance was reported and acted on. You might want to summarize any faults that you've come across in that time and remedial actions and any further actions. So if there's a fault that hasn't been dealt with, this is the time to tie up those loose ends. So a very simple process, but it just makes sure that everything's working properly.
So Nick, I know from people that have implemented user QA recently that occasionally they see something out of tolerance. How do you recommend they manage that?
If it's a quantitative result out of tolerance, like the sensitivity, then you should always repeat the test, check your settings are right. If it's still out of tolerance, then a good follow-up test is some sort of measure of sensitivity with a phantom, either a penetration measurement or looking at the gray levels. If you can't do that, if it's only slightly out of tolerance, you could wait till the next month and see if it's still out of tolerance. And at that point, you need to be taking some action if it doesn't come back into tolerance.
Great, thanks, Nick.
Yeah, can I just say a little bit more? Obviously, if you've got things like dropout and delamination, you need to risk assess those. And I would say if you've got one line of dropout, the evidence seems to suggest that that's not going to affect your imaging or Doppler. But any more than that, it's quite likely to have an impact, at least on Doppler. and any delamination or major dropout, really you should be replacing the probe.
Thank you. So Nick, do you want to sum up for us? And I think then Marilla's going to open up the floor for some questions.
Yeah, the most important components are the quickest ones to do: the regular physical inspection and the uniformity check. And as we've said several times now, if you do this right, you're going to pick up more than 90% of faults. Then you've got a very simple sensitivity test, which is going to hopefully give you reassurance that there aren't any more subtle faults. These are all quick and easy to do, and there isn't any reason why we shouldn't be doing them in exactly the same way.
Great. Thank you, Nick. I think we'll ask Marilla to open up the floor to any questions. I think we may have been sent a couple of questions for some people that weren't able to join us today. So Marilla can bring those to us. I've just opened up my chat panel as well. So
thank you.
You can see that.
Yeah, if you have any questions, please pop them in the chat panel. I know that sometimes it takes a while for them to come through. So in the meantime, we have had some questions in advance. First one, who should be doing the audit? Who would you recommend does the audit?
If you've got someone coming in to help you, maybe physics or clinical engineering or an external provider doing your annual QA, they're an excellent choice to do an audit because they're going to be independent of the department. If that's not happening, then ideally someone who's not doing the QA on a particular scanner should audit that scanner. So if sonographer 1 is testing scanner A and sonographer 2 is testing scanner B, just swap over to do the audit, and that gives you a little bit of independence there. But there's no reason why you shouldn't be doing this within your own department.
Okay, thank you. And another one, in the years of experience that you've had, what sort of things have you found at the audit phase?
Sometimes I'll find that there's been the odd result out of tolerance that hasn't been reported, but then it's come back in tolerance next time. And I'm not concerned about that at all. Occasionally I've found perhaps a month or a couple of months during the year has been missed. And again, I'm not worried about that. That's going to happen sometimes. As long as there's a fairly regular QA process going on, that's fine. What would worry me more is if suddenly QA seems to stop, or it's very rarely done. And then I think I'd be wanting to have a chat with the local manager to find out what the obstacles are to doing QA and see if I can help in any way, just to give them a bit of support and encouragement. It might be maybe a bit more training's needed, or sonographers feel they haven't got enough time, but these obstacles can be overcome.
Good, okay. Another question is, can you do similar tests for a phased array?
Yes, you can. For a long time, we thought we couldn't look for dropout on phased arrays, but Darren and I developed a new test. The problem with phased arrays is the whole aperture, the whole array is used for forming each beam, and the beam is steered. So you don't get the nice axial bands that you get on linear and curved arrays. So the trick there is to switch off the beam steering, and you do that by turning on M mode. And then if you sweep the paperclip along the array, the M mode trace will show you any bands of dropout. So it's again a very simple test to do, and you can find dropout easily on phased arrays.
I think the manual refers to that as well, Nick, as one of the tests and describes it, doesn't it?
Yes, and it gives a similar test for multi-row arrays as well. So most types of arrays that you'll find in use at the moment can be tested in this sort of way.
Great, thanks, Nick.
Okay. Don't seem to be any questions in the chat panel. I think if there were going to be any, they'd have probably popped up by now. Is there anything that you wanted to add at the end at all, Darren and Nick?
Nick, you go first. please.
What haven't we talked about? Yeah, I think these tests can be done just in a few minutes. So what I would hope people start doing once they get into a QA program is actually looking at things every time they use the scanner. So if you chose to do a physical inspection of every probe and look at uniformity, if you've got to use a QA preset there, you can probably do that in less than a minute per probe. So just in the first 3-4 minutes in the scan room, you could have checked all your probes, excluded any major problems, and you'll know then that you're protecting your patient.
That's
Right,
great, thank you.
That's pretty much QA every day then, isn't it, Nick? Just a little bit and then the formal bits building on it. So that's great.
Yeah. Also, you'll know if a doctor came in the day before and broke your scanner.
That never happens, of course.
No, that's a purely hypothetical situation.
That's correct. No, I just wanted to say next time, Marilla, we're lined up with Nick to discuss baselining, which helps us with some of the quantitative measurements for our ongoing QA. And thank everyone for taking time out to join us today.
Oh, actually, and that is, I think, what we've had a question in the chat panel. How do we set up the user QA presets? That's next time's webinar, isn't it? It's a great question. Very well timed. Yeah. Thank you. Yeah. Anything else anybody has? Just if not, I think we'll call it a day. So thank you very much, everybody. And we'll see you at the same time next week, if not on the recordings. Thanks for taking the time out this evening. And we'll see you next week.
Thanks, everybody. Goodbye.
Thank you all. Bye.
Thanks. Bye.